My name is Henrik Zetterberg. I'm a professor of neurochemistry at University of Gothenburg and at University College London. My specialty is fluid biomarkers for Alzheimer's disease and other neurodegenerative dementias. How should we move these new biomarkers, the blood biomarkers, into clinical practice? I think the trick here is to have assays that are very robust and can give reproducible results when they are done week by week in a clinical laboratory. And that's not easy, but I'm sure that the biotech industry will make it work. I've been so impressed by what we have seen in the CSF biomarker field when looking at how tests for CSF biomarkers have developed over the past 5-10 years in terms of precision and analytical sensitivity. I believe we will see exactly the same thing happening for the blood biomarkers, and we already have. We are very close to this, I think. But what is needed is that we will have to examine these blood biomarkers in more diverse populations, because we should remember that the promising proof of principle studies, they have been performed in cohorts that are quite homogeneous in terms of inclusion criteria, and often most studies have been performed, most but not all, have been performed in Europe and the US. And we now need to check how well the biomarkers work in more diverse populations. That's one important thing. We also need to develop reference limits and decision limits, and we need to have reference materials that we can anchor the different biomarker tests to, so that different labs can report back results that are in the same concentration range at using one assay as compared to another lab using another assay. That's an important thing. And we will also need to validate these reference limits so that they are really reflecting Alzheimer's disease also in different age groups, for example. We have to look at confounding of other diseases in the body, like kidney disease, liver disease, cardiovascular disease, to make sure that the biomarkers work also in these individuals. There could be confounders that we need to pinpoint and learn how to deal with. But all this is, to me, all these things are relatively minor, because we already have the biomarkers, which is the most difficult task, and now we should just refine them. Once we have validated assays that could run in clinical chemistry labs around the globe, we also, not once, but in parallel with developing such tests, we need to educate physicians on how to use them. And this is, it's both trivial and not trivial. It's very important to get the message across that these biomarkers reflect brain pathologies, and that some of these brain pathologies have a relatively long preclinical phase. So it's important to know that when you see a patient and you decide to do Alzheimer biomarkers, the challenge for you as a physician will be to link the biomarker evidence of pathology to the symptoms the patient has. And to be very concrete, I would just like to mention that almost like a scenario which would be really bad. If you have a patient coming into your clinic asking for advice because of depressive symptoms and memory problems, and you perform a blood test and you detect amyloid pathology in that blood test, and also perhaps some tau changes, then you still won't know if these pathologies are the cause of the symptoms. It could be that you have detected preclinical Alzheimer's disease, but that the real cause of the problems that the patient sought your help for is a depression with some cognitive problems, and that you would need to treat this depression, and that the preclinical Alzheimer pathology might bother this particular patient in 10 or 15 years. And of course, you would do quite a lot of harm if you simply set the diagnosis of Alzheimer's disease and neglected the depression. Now, I don't mean that one should hide the biomarker result for the patient, but one could be very transparent and state that your blood tests for Alzheimer's indicate that there might be a little bit of Alzheimer's going on, but what I want to do with you first is to try to treat this depression. And I will follow you carefully and see how your cognitive problems respond to the antidepressive treatment. And then you are my patient, and I will follow you, and we will evaluate this carefully so that the right diagnosis and treatment comes in place to best serve the patient. Then I could also discuss wouldn't the patient get worried learning about the potential Alzheimer changes? But then one has to also be very clear and transparent as a clinician that Alzheimer's disease pathology is extremely common, and the clinical course is variable. If there are symptoms indicating that these pathologies start to injure the brain in a way that could cause problems, then we have a number of treatments to start with. So then it means that this is all good for the patient. You get the control of the different processes that are ongoing, and you will get through the way the physician communicates with his or her patient. The patient will feel like, okay, I have a doctor who knows about this and knows how to deal with these tests. So education on how to use the tests will be extremely important. And the way I see CSF in this context is exactly when you have biomarker patterns in the blood that are a little bit gray zone, a little bit hard to tell if this is or isn't pathological. Then I think a very reasonable next step would be to either do the lumbar puncture yourself or refer the patient for lumbar puncture and analysis of the same biomarkers to see if the picture becomes more clear. It's not more important for the Alzheimer biomarkers than for any other clinical chemistry test we are using. It's definitely not rocket science. These biomarkers are not particularly sensitive, but it is good to implement a simple, straightforward sample handling protocol, which is then perhaps similar to how you sample for homocysteine in plasma. If you use that regular clinical chemistry protocol for how you best take a sample for homocysteine, you will have a perfect handling of the sample to also do the Alzheimer biomarkers. So it's important. It has been quite well studied also, but it's definitely not a big problem. It will be easy. That is not a hurdle for implementation in the clinics.